The amount of time spent in the recovery room varies depending on the type of surgery, type of anesthetic, location, office versus surgery center versus hospital, for example, and even geographic location. Different facilities, cities, and states may have different rules. Your anesthesiologist should have a good idea of how long you may expect to be in the recovery room for a particular surgery. Actual time spent in recovery may not matter as much to you as it will to anxious family members and friends in the waiting room. You may not be completely free of anesthetic drugs when you were discharged, but you should be sufficiently recovered to be able to leave with an adult after outpatient surgery or with the care of nurses should you be staying in the hospital. The typical stay in the recovery room following an anesthetic for surgery is at least an hour, sometimes more. What will your recovery be like? Simply put, recovery is a process and not an event. It is entirely dependent upon the choice of anesthesia and whether any issues or complications arose during surgery to alter either the surgical technique or the anesthesia drugs administered. Other variables affecting recovery include your health, your medications, your surgery itself, and how much discomfort you are in following surgery. In cases where local anesthetic only is used, the patient may be immediately discharged. In the case of any anesthetic other than exclusively local or topical, that is, general, regional, or local anesthesia with sedation, you must make arrangements for a ride home. Although the medications are usually rapidly processed, there are wide variations from person to person. Some patients are ready for their next meal in the recovery room, while others may feel the need to lie low for a longer period. It is also a good idea to have a responsible adult with you for 24 hours following your procedure.
You may already know the answer to the next commonly asked question: will you be with me the whole time? In fact, on the day of your procedure, the anesthesiologist will be with you for a substantially longer period of time than will your surgeon. The anesthesiologist is with the patient from before the patient enters the operating room, during the process of putting the patient to sleep, throughout the surgery, and during the initial phases of recovery. He or she is the guardian of your welfare when you're unable to speak for yourself. This being the case, the anesthesiologist needs to be with you throughout your surgical event. This is not the case with family and friends. As a general rule, for outpatient surgery, friends and family can expect to be with you in the waiting area just before your admission to the preoperative holding area and again after discharge. If you're hospitalized, loved ones can usually wait in your room or the surgical waiting area. One of the reasons for this rule is a federal government regulation protecting patient confidentiality. This rule is called HIPAA. The public is not allowed access to information that can be used to identify another patient, such as name or face. There are exceptions to this rule, such as in the case of a parent accompanying a child into an induction area so that the child can be put to sleep in the presence of his or her parents. This, however, is not universal. A reasonable facility will offer progress reports to designated friends or family on a regular basis until the patient is allowed to accept visitors or to be transferred from the recovery area.
When exploring medical treatment options, it is generally required to discuss the benefits, alternatives, and risks associated with those treatments. This is true for surgery, and it's true for anesthesia as well. Two of these three issues, benefits and alternatives, can be dealt with in a relatively straightforward way. That is, if the patient is committed to having surgery, the alternative to not having anesthesia is to not have surgery. Think of it this way. There aren't any real alternatives to anesthesia, although there are alternative types and styles of anesthesia. Patients are well within their rights to ask for specific alternatives within the proposed anesthetic technique. Non-surgical procedures such as endoscopies, cardiac catheterizations, radiographic studies, some contrast studies or dye tests, claustrophobic patients for MRI or CT scans, biopsies and the like, are also performed with some sort of anesthesia. Everything said for surgical anesthesia applies to these situations as well. The risks of anesthesia are an entirely separate discussion. Most patients' concerns center around, will I wake up? In 1950, the death rate due to anesthesia was 1 in 5,587. In the mid-1970s, it was 1 in 45,000. 1980 saw it reduced to 1 in 143,000. And in 1989, the death rate was 1 in 250,000. Today, it is in the neighborhood of 1 in 400,000. Between 1950 and 2000, there has been an 80-fold increase in the safety of anesthesia. This is due not only to changes in anesthetic drugs, but increased training requirements for anesthesiologists and the development of associated advanced monitoring techniques. Years ago, manual blood pressure cuffs were used and primitive devices measured EKGs and pulse rates. Expired gases could not be analyzed. We are now fortunate to have machines that measure blood pressure automatically. Multi-channel EKG leads are widely available. Computer algorithms actually analyze changes in the heartbeat and electrocardiogram waveforms well before an irreversible change can take place. Body temperature and oxygen amounts delivered to the tissue can be measured. Measurement of the amount of oxygen delivered to the tissue with each beat of the heart is routine. We measure, quantify, and analyze the contents of inspired and expired gases with each breath the patient takes. We know the percentage of oxygen, carbon dioxide, nitrogen, and anesthetic gases virtually continuously. Brain waves can be measured under anesthesia for certain surgeries and can act as a depth gauge of the level of anesthesia. We can also measure airway resistance changes during surgery for an early indication of allergic responses, allowing treatment even before such changes as drops in blood pressure or shock can occur.
All of this information allows us to intervene for the patient's safety well before a problem can develop. Some monitors even have pulmonary or lung function testing capabilities. Be sure your surgery location offers monitoring equipment meeting the standards of the American Society of Anesthesiologists.
Truthfully, you are more likely to be injured in your kitchen, bathroom, or car on a daily basis than to ever experience an anesthesia complication of a significant nature. However, there remain risks of anesthesia, including but not exclusively limited to bleeding, bruising, nerve damage, infections, allergy, inadvertent misplacement of injectable medication, intubating the esophagus instead of the windpipe, chipped or loosened teeth, temporary or permanent visual field loss, and other unpredictable effects. Each of these incidents and many more have occurred, but the rate of occurrence is very low, often below the legally defined threshold for identifying potential complications. It is said that statistics apply to populations, but complications occur to individuals. Complications that do occur can be the result of insufficient disclosure on the part of the patient. Portions of the medical history that seem unimportant to the patient may be critically important to the doctor. It is imperative that, for the patient's safety, each question in the preoperative period be answered truthfully and completely. The medical record is confidential, and that confidentiality is federally protected by the HIPAA Act. Do your part to avoid complications by being open and forthright in answering questions. You can also lessen the risk of complications by a thorough evaluation of your surgical team, the surgeon, the anesthesiologist, and the facility.
I continue to be amazed by the number of patients who, with little or no investigation, choose a doctor solely on a friend's recommendation. Exercise due diligence on your own behalf. Unfortunately, there still can be complications even if everything is done properly. The existence of a problem is not necessarily an indication that something was done wrong. No competent physician intends to harm you. By definition, accidents are unintentional. The practice of medicine blends art and science. Most medical accidents are just that, accidents, and are not due to intent, lack of caring, or incompetence.
The following video segment follows a patient immediately before and after receiving general anesthesia, as well as her stay in the recovery period following the procedure.
Dr. Novak,
Hi.
I have the honor of giving you your anesthesia for the events of today.
Okay.
Before we do that, there are several things that we need to go over to try to make you more comfortable, to help us prepare, and to make sure that we can do the best possible for you today. Okay, so I'm going to ask you a series of questions that'll be kind of boring and repetitive because I'm sure you've been through them before.
Okay.
Then we'll go through some other issues and you'll have a chance to ask any questions if I don't cover it. Okay?
Good deal.
All right. Do you have any allergies to any medications that you're aware of?
None that I'm aware of.
Do you take any medications on a routine basis?
No.
Okay. In the past, have you had any surgical experience at all? That is, have you ever been put to sleep for anything or had a regional anesthetic?
No.
Okay, so this is your first experience
Yes.
in all of this.
Yes.
All right. So if this is the first experience you've had with anesthesia, there are some additional things that we need to go over since you don't have a whole lot to relate to with this. The issues with anesthesia tend to be around control or maintenance of the airway, that is, being able to breathe for you, or issues with drug problems or allergies. So we've already established that you don't have any allergies. We've established that you don't take any medications on a routine basis. So we're not expecting any problems there. Nonetheless, there's about a 1 in 15,000 chance on any given day that you could be allergic to some medication that we give you. So we have to be prepared potentially for that. You have no history of having had anesthesia before, so your odds of a significant adverse reaction exclusively due to the anesthesia are somewhere in the neighborhood of 1 in 250,000 to 1 in 400,000.
That's pretty good.
So there, that includes things like allergies that are significant to the anesthetic agents, a thing called malignant hyperthermia, where your body's temperature regulating mechanism goes haywire, or other bad things like I knew somebody whose aunt didn't wake up from an anesthetic once upon a time. So it includes all the weird stuff. Typically, we're supposed to talk to you about things that occur 1% of the time or more. And there aren't any of those bad things associated with anesthesia that occur at a rate of 1% or more. So all of the things that happen with anesthesia, whether it's not waking up, having a stroke, having an airway problem, having a heart attack under anesthesia, having anaphylaxis or a severe allergic response, all those occur at a rate of less than 1%. So I could sit here at this point and say, well, that's it, we're done talking about things, but that doesn't really give you the information that I think that you need to have going into this. Surgery is always associated with pain afterwards, because unfortunately our surgical friends have to do things that might cause you to have pain. The operation itself can cause that. Sometimes the pain is a sign that something's wrong. One of the things that we'll often do is put a local anesthetic in or around the site of surgery so that you don't hurt so badly afterwards. And we have that planned for the surgery that you're set up for today.
Okay. When will that wear off?
Well, it depends on the drug that's used, but the one we've selected for you today should last into tomorrow. Okay? So by that time, the pain medication that you'll be able to take will be able to at least dial the flames down on the pain afterwards, if not make it totally go away. At least it should be in the bearable phase. We can't predict everything, but the way we get a handle on trying to anticipate problems is with the monitoring devices. When I started my training, the odds of a significant problem with anesthesia were in the neighborhood of 1 in 6,500. So they're at least 40 times safer than that currently, and the bigger changes have been not only in the drugs but in the monitors. So we have monitors to watch your heart rate with each beat of your heart, your blood pressure every couple of minutes, the amount of oxygen delivered to your tissue with each beat of your heart. With each breath that you take or that we give you, we analyze the gases going in and out, so we know how much oxygen is going in, how much oxygen is going out, how much carbon dioxide is in, how much is out, how much anesthetic gas, if we're using that, is in, how much is out. We have monitors of anesthetic depth so that we can measure how deeply asleep you are, and we even have monitors that allow us to do continuous pulmonary function tests while you're asleep. And that's what we're talking about for you today, is going to sleep for the surgery that you're having. Some surgeries can be done under a regional anesthetic where only a part of you goes to sleep or gets numbed up for the surgery, whether or not we give a sedative. But for the surgery for you today, a general anesthetic is a better choice for most people. So you have no contraindications to a general anesthetic. One of the things I mentioned earlier that we're concerned about is control of your airway or being able to breathe for you. So there are a couple simple little tests that we kind of go through to see if that's going to be a problem. So if you look just straight ahead for me, hold your chin level, and let me see how many fingers we can get under your chin, which is more than 2, so that's a good screening test. Now if you look towards me, open your mouth, say ah, stick out your tongue. Okay, and I can see all of your uvula and your tonsils and halfway down your throat. So I don't anticipate any problem based on that brief evaluation of your airway. As you're aware, we've already checked your heart, we've checked your lungs, we've checked the lab tests before you ever got here, and all of those were passed. So we've checked every known organ system that's pertinent to this. I mean, your brain's another issue since you're silly enough to sign up for this. I don't know what to say about that. What I can do though is ask if there are any questions that you've got that we haven't covered to this point.
Yeah. What if I wake up during?
That would be a big if. There's a statistical occurrence rate of awareness under anesthesia. Those situations typically occur when the anesthetic is very light and when muscle relaxants are used so that you don't move. In the surgery that you're having today, you will not be paralyzed during the surgery. Movement away from something that hurts occurs long before consciousness occurs. So an avoidance attempt by you under anesthesia is interpreted by me as you needing more anesthesia. Independent of that, we have depth of anesthesia monitors to kind of keep track of the state of your brain and the brain waves during the anesthetic so that we can know these things. That gives us a measure of protection. Sometimes there can be mechanical faults or failures or earthquakes or disruptions in the supply lines that may force an unavoidable situation. I think with the monitors that we have, with the way that we're going to look after you, it would be exquisitely unusual for you to have any awareness under anesthesia. Completely waking up under anesthesia without our intending to have you wake up would be unheard of.
Now, do these machines have to be tested? There's no malfunctioning. They have to be certified.
All the machines are inspected. They are safety inspected on a regular basis. That's required by the certifying agencies for all of the healthcare facilities. So whether it's the federal government or any of the other voluntary organizations that facilities go through, the machines are tested. They're tested on a daily basis. They're tested in between cases as well, and they're retested again before we start a surgery on a following patient on any given day. So that's
good deal.
Yeah, they're mechanical devices. I can't tell you that they won't break, but I can tell you that we've got the parts available to fix darn near anything that occurs, including a spare anesthesia machine in case the thing goes completely haywire.
Good deal, good deal. And when can I start eating after I wake up?
That's going to depend on how you feel. Certain types of surgery have very specific limitations on when you can eat or drink afterwards. For the surgery that you're having, it will really depend on how your head and your stomach feel. One of the biggest problems following surgery is post-operative nausea and vomiting. That can occur anywhere from 10 to 40% of the time. With the way that we manage our patients, the occurrence rate of significant nausea or vomiting after surgery is less than 1%. So,
nice.
If people taking care of you are aware of the potential of the problem, there are several steps that they can take that will reduce the chance of nausea or vomiting afterwards. Nonetheless, you may not feel like eating, in which case you don't force yourself. There's no upside to forcing yourself to eat just about at any time. And what I advise most patients to do is kind of listen to your inner voices. If somebody says the chicken soup will be great for you and you're going, nah, chicken soup doesn't sound very good, then listen to yourself and not the other person.
Right. Okay.
So,
all right.
anything else that you want to cover at this particular point?
One of my questions was, during my surgery, what are you going to be doing?
Oh, apart from reading and writing and making telephone calls, I'll be... No, seriously, that's a very common question. If we do everything right, getting you started in surgery, then the anesthesiologist's job during surgery is really a lot of fine-tuning. It's a lot like the pilot, where the takeoff and the landing are the problems, and it's the same sort of thing in anesthesiology. Getting you off to sleep and getting things started is more difficult often than what goes on during the time. We've got to monitor you continuously. I told you we're monitoring what's going on with each breath that you take or that we give you. We're looking at the oxygen delivery to your tissue with each beat of your heart, and we're continuously evaluating that. What we're trying to do is get information ahead of time that leads us to predict the oncoming of a potential problem so that we can stop it before it occurs. I'd mentioned earlier the pulmonary function test. If you're going to have an allergic response, one of the first things that changes is what's called the airway resistance, where your breathing tubes start to get a little bit tighter. We have a monitor that'll tell us that. Okay. So if we start seeing your breathing tubes get tighter, I can presume that there may be an allergic response coming up. Start looking for what it might be related to and take some steps to either prevent it or, if it occurs, minimize the problems for you. So really, during the case, we're troubleshooting. I stay with you the whole time, from before the surgery begins until after it ends, and then we'll get you checked back into the recovery room, where your care will be transferred to an experienced recovery room nurse to help you regain consciousness and get ready to go home.
And how soon after my surgery is done am I going to be waking up?
I think that with the anesthetics planned for you today for this particular surgery, we should be able to have a coherent conversation with you within 5 minutes after the surgery is done. You may not remember it because we may give you some medications to help with pain or something else that helps you not remember it. But I anticipate being able to have coherent conversations with you for this type of surgery very shortly after the surgeon puts the last part of the dressing on.
Good deal.
So,
let's rock and roll.
Well, the first thing I've got to do is get an IV started.
Oh, okay.
Oh, okay. Yeah, that's the rude part. Yeah, that's the source of some other questions that patients come up with on a routine basis. Now, a lot of times you go to get your blood sample taken for your lab test, and you get a tourniquet placed on your arm.
Okay.
And then somebody wipes the vein with alcohol, and then they just draw your blood. Well, I've been a patient. It's got to be a little tight. I don't want it to pinch the skin. But having been a patient, I'd like to be somewhat sympathetic and empathetic.
Yeah, please do.
The first thing we'll do is put some alcohol on the site that we've selected. We'll let that dry. I want to make the vein mad at me, but I don't want to get the rest of you mad at me. I haven't met too many patients that like needles, so I apologize, but I'm going to give you a local anesthetic here first to make the rest of the process easier for you. I get along just fine with patients that don't like needles.
Great.
It's those that like them that scare me. You know? A lot of times with multiple surgical procedures, somebody may become indifferent to needles. But those that like them. connect up to that. Make sure that it's running okay. So the IV's running fine. Get some tape on it.
So it's just hanging out of my hand?
Well, sort of.
Okay.
But now, it's officially taped in.
Is it safe to look?
Yeah, absolutely. One of the common misconceptions that patients have is that there's something sharp or something metal in the IV catheters are mainly Teflon or a plastic material, and within 2 to 3 minutes after being placed, they warm up to body temperature so that they're soft and flexible, and you can bend your hand or move your arm without hurting
So
things.
it moves with me. So
It moves
this
with
cold
you, not
feeling-
against you. The cold feeling that you've got is the fact that the intravenous fluids are at room temperature by the time they hit your skin. So even if we warm the bag before it goes up, by the time it drips through the tubing and gets to you, it's pretty close to room temperature. So it feels cold.
Okay.
It feels cold because it is.
Okay.
So let's slow that down.
Okay.
We pull the railing up, and we'll move on to the next step. Michelle, after everything we've been through, do you have any helpful tips to help other patients that may be trying to plan for their upcoming surgery?
Yeah, I think it's definitely important to have a nice long talk with your anesthesiologist before a couple days, even prior to surgery, just so you know what to expect, you know what you can eat and drink, and even down to chewing gum, and up to how long before you go into surgery. It's very helpful. It makes you sleep better.
Well, for you, for instance, there was a specific set of directions that we went through. Those directions for you, for your surgery that you're set for today, may not be pertinent to another patient. So it's also important that the anesthesiologist be knowledgeable about what the surgeon's needs are so that you don't get conflicting directions, and make sure that you get all your questions answered.
Right, and times.
The times?
The times are important.
What?
As far as how long you can drink and eat up until.
Okay. Yeah, because